This is Roger Green, host of the Surfing the NASH Tsunami podcast. Today, we are offering 5 conversations from episode 27, our preview of key sessions and abstracts at next week's EASL Congress 2023, plus a 6th separate conversation with Arun Sanyal and David Kleiner on the benefits of AI-assisted histopathology in anticipation of a major prospective study on the topic. This conversation continues the discussion between Jörn Schattenberg, Ian Rowe, and me over key items and abstracts in the EASL 23 Congress. In this conversation, we begin to review the various meeting sessions related to NAFLD or NASH and discuss what we find exciting or intriguing about each session. Jörn starts with the NAFLD Therapy session Friday morning at 8:30, or as he puts it, for early risers. 4 of these papers are about drugs in development, and the 5th is about intermittent fasting as a strategy compared to calorie-restricted diets. Each is interesting and promising. Among the drug papers, 2 look at dual GLP-1 glucagon agonists, ethinopeptide from Merck and pemvidutide from Altimmune. Another paper presents phase 2b data on denifanstat, the much-discussed, eagerly anticipated FASN inhibitor from Sagimet Biosciences. The last of the drug papers looks at an siRNA agent targeted at the PNPLA3 gene, a widely studied gene defect linked to NASH. I discussed this paper, linking it both to previous episodes where we discussed the value of siRNA as a system to deliver sophisticated gene therapies to specific targets, and also this agent's conceptual similarity to inclisiran, another siRNA developed by Alnylam, this time to reduce LDL cholesterol, with which I have extensive experience from my days as a forecaster and marketing researcher. With major drug development presentations led by the Meister NASH results, new material on diagnostics from Litmus, Nail and IT, and others, and the nomenclature presentation, the EASL Congress will be 3 very packed days. We will be reporting twice on Saturday, once before the Saturday session and once afterwards, and I may attempt to post some one-on-one interviews on Thursday and Friday. So, when listening to this episode, think about what you want to attend in person or virtually, and just sit back, listen, enjoy, learn. When you're done, join the dialogue in our LinkedIn discussion group.
Jörn Schattenberg.
I think we have to move on from the NITs and actually talk about the next abstract session. And the next one that obviously sparks the eyes if you move outside of the general and late breaking is the NAFLD Therapy session, which is on Friday morning, 8:30 a.m., so early rise. And there is 5 presentations, 4 discuss pharmacological interventions, and actually 1 presentation of a young investigator is related to time-restricted feeding. This is a young investigator from India. The concept is very interesting and want to touch it briefly because we're doing a similar study. A fellow of mine who's working in Italy, in Turin actually, has done the same thing. Here in that abstract, it's oral abstract 064. They have 68 patients in time-restricted feeding. And I think the first gap in this is to keep the patients on those strict dietary requirements with 8 hours of feeding and 16 hours fasting. And for most of my patients that I approach, that's not feasible because of work shift or something. But if they're successful to stay that, they have a number of non-invasive tests they're assessing. This is actually mostly done by FibroScan here. They're calculating fast. Obviously, the time-restricted feeding was better than calorie restriction on liver stiffness and CAP improvements. So I find that very interesting. I find it interesting because it's plausible and it's easy to explain to patients. All other dietary interventions are complex and more difficult to detail. If you tell them you eat then and you don't eat then, that's pretty straightforward. So I'm a fan and I actually advocate for that for some of my patients. It's not an intervention that is aimed at weight loss, but it restores insulin sensitivity. So for that reason, very interesting.
Roger Green.
Yeah, that's fascinating. I have friends, social friends, who've attempted that regimen and argue that even if you can't be completely successful every day, one is a senior vice president of a Fortune 100 company and does not have that kind of control of her schedule. But she's lost significant amounts of weight. I'm going to guess maybe 15% of her body weight in a 6 or 8 month period, and has seen her HbA1c is driven below 6. And she's had a couple of other things that suggest that she's really had tremendous success with it. Now, that's an anecdote. But the only reason I mentioned that actually in context is that's with imperfect execution. I'm not sure you have to hit the letter of the law on this one to get most of the benefit of it, would be my only question. I don't know how one proves that in a study, because that assumes that, I don't know how one proves that in a study, but I'm not sure you need perfect execution for this to be a successful strategy.
Ian, do you have anything in that treatment session that raised your interest?
Ian Rowe.
Well, I think there's quite a few interesting abstracts in that session. Some of them are sort of relatively familiar. The first abstract, OS060, which is the phase 2A randomized active comparator open label study to evaluate the efficacy and safety of Merck's new drug, which has a name that I haven't heard pronounced in public. And almost.
You have to say it. It's ephenopektitide.
Well, it sounds like you can't say it, Jorn. This is a
Ian, no guts, no glory. Well, no, what, ephenopektitide? Pegtitide?
Yeah,
sorry.
Pegtitide. There you go. That'll do. I mean, this is the sort of direction we're headed. This is active comparators. So this is a combination GLP-1 glucagon receptor co-agonist, a bit like one of the other drugs later on in the session. And it's in comparison with semaglutide. And one of the other abstracts I'd quite like to talk about is one that Jorn's been involved with, looking at real-world, or not quite real-world data, but other non-NASH trial data for semaglutide, because I think it's inevitable, likely, that many of our patients are going to be treated or will have received treatment with semaglutide or another GLP-1 receptor agonist, and trying to understand what the additional benefits of treatment are going to be is going to be important, particularly, as drug development continues and perhaps the regulatory pathway might change with licensed drugs. So I think beginning to see data like this is really important, and this is an early phase study, but they report really quite striking rates of reductions in liver fat by MRP-DFF, and it's greater reductions with the co-agonist rather than with simply just the semaglutide. And we'll begin to see what this will look like. I think as a sort of headline figure, the proportion of people with a relative liver fat reduction of more than 70% is itself nearly 70% with the co-agonist, compared with 12% with semaglutide alone. So it's these are quite striking results, and I think it'll be really interesting to see how that reads through into 2B and then into later phase studies perhaps.
I agree, Ian. And I think we're following the obesity field here a little bit, and we're seeing how much more potent those dual agonists are. And the second one, the pemvidutide, is also a dual agonist. Now, if we start to discuss them, it's important that we remember that they have different agonism or strength of binding to those receptors, albeit they're activating both the same receptors. The ratio of GLP-1 over glucagon is important for the effect size and also for side effects potentially. So albeit in the same class, I think the profile could be very different, and that will be very interesting to learn. So also always have to look at the safety aspects of these. And I mean, the other two mechanisms that are discussed in that session is a FAS inhibitor, and we've seen some of that compounds earlier. So Rowe abstract 061 is going to present data on denifanstat. I'm not sure that was 100% right, but it's interesting. Only 26.
Close enough.
Close enough, right? 26-week interim analysis of the FASCINATE-2 trial. The FAS inhibitors are a class that keeps promise. And then a very new MOA with the RNA interference. I think that's fascinating because it's really down to individualized therapy here, and we're seeing in other indications the applicability of this. And here, targeting the hydroxysteroid 17-beta dehydroxygenase 13 is really novel, I think.
That one I have a couple of points about. First of all, one of the last things I did before I left marketing research was the global forecasting and benefit strategy for inclisiran, now known as Leqvio, which is like this molecule, a siRNA dedicated for a specific target, in that case PCSK9, and developed by Alnylam. And Alnylam marketed with the Medicines Company, which was eventually sold to Novartis. This is Alnylam and Regeneron, but fundamentally very, very much the same concept. Okay. Second, Jorn, I don't think you were a co-host yet, but at one of the meetings in 2021, Mike Charlton suggested that he thought the most interesting abstract in the entire meeting was a late-breaker poster for an Arrowwood siRNA that subsequently had its development discontinued. A month later, Novo bought a company that had its own siRNA. So we're now starting to see this stuff bear fruit. And then we had an episode with Scott Friedman where he actually talked about the idea that they now can put miRNA together with CAR-T and go directly after fibrosis that way in an individualized way. This is, I think, one more early shot in what's going to be a fascinating set of advances. You can really hit a target dead on. And CAR-T became an issue in oncology in part because you're using externally generated material. But here, you don't have to take anything out of the individual. You can just target the gene and go. I expect we'll see a lot more of this in years to come. And yeah, I agree with you. I think it's a fascinating area.
Yeah, the limitation of it is a little bit, you always have to, in these earlier studies, they show target engagement in the liver, so you still need liver biopsies. It's not, to also show you knocking it down. And I'm not sure how long we want to continue this, but it's interesting to see how strong the decrease even in liver tissue will be.
I think actually the benefit of the therapy will determine whether we continue doing biopsies. Once we've got drugs in market, that's going to become a lot less attractive for everybody. And once NIT is accepted for drug approval, even more so. But I would guess that there will be a way around it for a therapy like this because this stuff has some really interesting potential to it. On the other hand, I'm not a hepatologist, so I'm like the last person who should render an opinion on that.
Roger, I think it'd be interesting to see if there's any sort of biological signals of activity that can be identified in something that isn't liver tissue. They'll be looking hard for that, and I imagine, and even if it's just ALT or AST, something to indicate activity beyond target engagement on the biopsy. But I guess we'll see. I agree. I think it's a really interesting presentation. Very, very early phase in that session, which is a contrast to everything else. And I share the interest, perhaps a bit less the excitement, because I think, the way the field's moving, I'm not sure how it would fit in the sort of therapeutic environment in the future. But I think the biology is really interesting, and understanding whether you can have a therapeutic benefit with that sort of strategy will be really interesting.
Well, so there, Ian, I think we can actually steal a page from cholesterol, which is that when we got done doing as much good as we could do with small molecule, PCSK9 was identified, and 2 agents targeting PCSK9 more directly came to market with Q2-week dosing and very, very high development costs. And Leqvio's Q6-month dosing, and is not quite as efficacious against cholesterol. I think something in the range of 50% versus 56 or 57% drop after high-dose statin. But if you can do that in 2 doses a year in patients where you've already worked your way through all the small molecule therapies, there should continue to be a place for that, I would guess.
Yeah, I totally get that. I think it's about biomarkers for efficacy and response, and perhaps even mechanism-specific biomarkers. And I think understanding how we will gauge treatment response in individuals, and whether we will have response-guided therapies, or whether these will be therapies that we'll use in the longer term. They're still open questions in my mind, and it speaks to the amount of work that's going to be required if and when a drug is licensed, because there will be so many questions still open about how we actually use these drugs in practice that keep us and the podcast and business for many years to come.
And now, back to Roger.
We hope you've enjoyed this recording. If you have any questions or comments about the content of this conversation or the entire episode, please put them in the review section of the page from which you downloaded this conversation, or send an email to questions@surfingnash.com. We hope to be back early or middle next week with a preview of the ADA convention in San Diego. We will clearly be back next weekend with a bunch of coverage at the EASL event itself. So until then, stay safe, surf on. We'll see you on the podcast. Bye-bye now.